Hello again. I get the privilege of hanging out up here for the next 45 minutes because I'm going to give you 3 talks that I like to think of as flash talks. So they'll be 15 minutes each. We'll cover a couple different topics in broad strokes so that I can give you some highlights on a few things. But the first one we're going to talk about is the perioperative management of the patient with chronic opioid use disorder. Because it's 15 minutes, I'm going to stick to methadone, buprenorphine, and Suboxone, and a little bit about naloxone. Again, no conflicts of interest. We're going to talk about understanding the issues surrounding chronic opioid abuse, how to manage the medications when you see it. And then I already talked a lot about multimodal analgesia, but I'll just briefly discuss it again. So substance abuse disorder is a major public health concern in the United States and around the world. The studies I was looking at showed that approximately 136 people die a day from an accidental opioid overdose. And an estimated 40.3 million Americans used an illicit drug in 2020. And now we all know that's when COVID came. And after COVID, there was lots of waves of depression and feelings of isolation. So that number, the illicit drug use, actually went up. Substance abuse disorder is a medical illness caused by the repeated misuse of a substance or substances. It is characterized by significant impairment in your health, your social function, and the ability to control what you're doing to yourself. So you actually can't stop using a substance without having mental or physical issues related to it. The way that you diagnose this is via 3 different categories. So that's going to be your cognitive category, your behavioral category, and your psychological symptoms. So we'll start off with a question. Which of the following is not considered a barrier to obtaining treatment for substance abuse? Geography, finances, stigma, or they're all barriers? I'll just give you 5 seconds. So the answer is all of them. So in 2018, a study came out that showed that 21.2 million people were actually diagnosed with substance abuse disorder, but only 11% of the 21 million actually received specialized care in relation to their disorder. And that's because of the barriers mostly. The cost of the treatment, you have to be able to afford it. The location of the treatment, you have to be able to get there, which means you either need someone to take you or you need to have a car. And I know for a lot of methadone clinics, you have to go every single day. So if you can't physically get there, you can't make use of that treatment. There's also the stigma, a lot of stigma. I don't know how many people you all see, but I get at least 1 to 2 patients a month that come in with a flag on their chart that says they're on methadone, but their husband, wife, mother, nobody knows that they're on it. So even if they are seeking treatment, they don't even want to tell their loved ones that they're having a problem. So there's also the access. There are a low number of buprenorphine prescribers, and there's a stagnation in the accessible opioid treatment programs. And then there's also no new drugs coming out. And that's partially because it's not financially lucrative for different organizations to want to invest in drugs for substance abuse. And also, if you were doing research, if you enrolled people who have substance abuse disorder, sometimes it's hard for them to actually stick to the treatment and they will relapse, and then there goes your study. So there's just not a lot there. For us, the perioperative period is an opportune time to screen for substance abuse disorder, and while we have them with us, initiate treatment. So we'll talk about methadone, buprenorphine, Suboxone, and naltrexone. I put this chart here because I know you all have access to these slides. It goes over the mechanism of action, the administration routes, the purpose, and the effects on the opioids, with opioids. Buprenorphine is a partial agonist that acts at the mu-opioid receptor. Suboxone is buprenorphine, but it also has naloxone with it, but the naloxone is only activated if you inject it. If you take it orally, you'll just have the buprenorphine effects. Methadone is a full agonist at the mu-opioid receptor, and naloxone, blocks everything. So if a patient is taking methadone, if they come in to see you, continue the home methadone throughout the perioperative period. Don't tell them to skip a dose. If they did skip a dose and you have the ability to give them their dose before they go back for surgery, do that. When methadone is as a pain physician, it's really hard to overcome pain in someone who takes methadone with my standard medications. So I just start it all because then at least they're at their baseline and I can add pain medication on top of their baseline. I'm not starting from the negative and trying to like fight my way up, especially if you like methadone, like 100 milligrams a day, it's impossible. You do need to be aware of their QTC. One thing that you can do, and again, although I do a lot of acute pain, I am not an addiction specialist. I have an addiction team and we work hand in hand together with some of these very complex patients. But if you take your methadone and you split it into TID dosing, so instead of like once in the morning or evening or twice, if you split it up, it actually will take on more of an acute pain analgesic effect and last about 6 to 8 hours. Let's see, and then you add the multimodal on top of that. So we'll do another question. How would you advise a patient prescribed buprenorphine who is scheduled for a knee surgery? Would you continue the medication without stopping? Would you stop the medication a week earlier? Because remember, this is that partial agonist. Or would you skip the morning dose on the day of surgery? And we recommend actually continuing it. Buprenorphine, Suboxone is a partial opioid agonist with it's 10 times more potent than oral morphine. Just keep it going. Don't cut down the dose. Don't skip a dose. It is a lot easier for them to have it and then for you to use multimodal or to use narcotics that are a little bit more competitively binding like Dilaudid when you need to. The reason that you don't want to stop this, or one of the reasons, is again 15 minutes, is that if you stop the buprenorphine or Suboxone, you put your patient at risk for cravings. And even like having that one little miss, if they go back and use whatever drug they were using before, they could accidental overdose just because they got a craving because they're not actually taking that, whatever they were taking, they stopped and now it's too much for them. So it just puts them at risk. This is another thing you need to watch QTC for. These drugs come in a subcutaneous injection, implant pill, and the Suboxone is a sublingual film. And you can also work with your addiction team and split this drug into BID, TID dosing, and it will also help in the acute pain phase of the perioperative period. Naltrexone, this is an opioid antagonist. I definitely recommend discontinuing this for 48 to 72 hours prior to surgery. If you have an emergency, you just have to really lean on your multimodals to get through. But if you have an elective surgery, stop it. Stop the intramuscular if that's the dosing that they're doing a month ahead of time, and switch them to, like, bridge them to oral naltrexone so that you can stop it a couple days before. People with naltrexone, the multimodal I would lean on are the nerve blocks, the ketamine, and then the other general ones like lidocaine patches, NSAIDs, Tylenol, if they're an appropriate candidate. So pain management for the individual with opioid use disorder, but they are not in a treatment program. This is probably going to be the majority of people I see. So these are the surprise, I actually do this, whether it's marijuana or heroin or kratom or whatever. It's really important to identify these individuals preoperatively via your focused history and physical. They have a much higher risk of poor outcome, including premature discharge, because they'll be in a lot of pain, they'll have a lot of cravings. You're not giving them even sort of close to what they take at home, and they're gonna wanna leave and use what they have at home, which leads to aggravation, difficult like behavioral issues that you'll have between the nurses and the staff, and overdose. In fact, the highest risk for overdose death for these patients is in the first month after hospital discharge, because now they're not just using this medication, that whatever they are getting for recreation, but now they have a lot of pain, so they're going to experiment with themselves and take more medication. Withdrawal, sometimes you'll see someone come in, but they tell you they just took some medication or they took it last night. It can take 4 to 18 hours to see the withdrawal symptoms. Some of my patients, it took like 48 hours before they really started to come out of whatever combination of medications that they had taken at home. Buprenorphine is favored. If you have the ability to start them on treatment while you have them with you in the hospital. I call my addiction team. We have like multiple conversations. They might reject the idea of starting treatment for their substance abuse, but we just try again. We're very non-judgmental and we just keep trying. Buprenorphine is favored over methadone because it's easier to titrate and because it's easier to obtain, because again, with methadone, you have to go to the clinics and most times you have to go every single day. I put this multimodal pain thing here for you to review if you'd like. The one I did add here, I did get a question during the panel about Precedex, which is an alpha-2 adrenergic agonist. So I'll just talk about that one because the rest I talked a lot about. It's good for moderate to severe post-op pain, but it can cause hypotension, sedation, and heart rate changes. The reason that Precedex is a good drug for pain is because it decreases the brain's sensitivity to the pain response, and it also improves sleep. And sleep is directly related to pain control, because if you can't sleep, you'll just be more and more sensitive and wound up. So that's why Precedex is a good choice, especially in the ICUs and in the intra-op area. So we're just going to do a case. I have John Smith. He's 38. He has opioid use disorder for 5 years, but he's currently stable and uses buprenorphine 16 milligrams a day. If you don't recognize that dose, that is a very standard dose for opioid use disorder. So when I see it, without even meeting somebody, I immediately think this person might be in a treatment program. I'm going to dig a little bit more into the chart before I go talk to him. He has no history of alcohol or benzo misuse. He has chronic gallstones and symptomatic cholecystitis, and he's here for a procedure. He's going to get a lap chole. So preoperative management. I want to ask him, how long has he been on buprenorphine? Has the dosage changed? Does he it's just us. Please let me know. Do you use anything else? Why did you start with the buprenorphine? How far back does that go? Because I really want to try to understand this person and the issues that they have and the barriers that they may overcome. And I want to build that rapport and trust up front. I want to know, do they have a pain management team or an addiction specialist? And if they don't, I can get them information about it. I would make sure that they took their buprenorphine that morning or whenever they take it, I'd make sure that they had that. And in most cases, I would not dose reduce. And I would administer, for these people, I would have that strong multimodal plan where I would consider the pre-op Tylenol, Lyrica, and Celebrex. And I would consider the ketamine and a nerve block. So into the OR, I will do general anesthesia. I would personally, I would do a quadratus lumborum block. Tap blocks are a little bit easier to do. You could also do a rector spinae if you have the time. But if you don't have any of that, you could run lidocaine during the case, or you can have your surgeon do, some surgeons can do field blocks or their own tap block. But this is gonna be very, very helpful with the pain, because when you add the narcotics on top of the buprenorphine, it's gonna reach a ceiling effect. I would also consider ketamine. Might sound like a bit overkill for a cholecystectomy, but I'd rather treat now to get ahead of the pain than have him howling in the PACU and trying to do like a quick catch up at that point. For post-op, we'd continue the 16 milligram buprenorphine, and then we would send him home. Sometimes people with substance abuse disorder are not able to go home, and they need to do a little bit of time, stay a little bit of time in the hospital just to get their pain under control. But if we do this, if we have this strong plan, most of the time we can get them to go home. So that would be your, again, Tylenol, NSAIDs, gabapentin, lidocaine patches. I would send them home with opioids. It would be more difficult because they won't work as well, but some low dose. I'd ask them what they've used in the past, hydromorphine or oxycodone, be a limited quantity, 3 to 5 days, and with follow-up. And then anyone who is on buprenorphine or methadone and you are sending them home with narcotics because of surgical pain, you also want to send them home with Narcan.